Janardhan for introducing the topic and the speaker.
Uh, Good evening, everybody. Thank you for giving me opportunity to introduce Professor Maheshwar Satapathy. He's the founder and CEO of the several respectful global organizations such as Global Health Forum, Global Brain, and the Mental Health Forum, and the world's largest only global consortium of the global health. He is a thinker led by the professional and led the global south. He is senior research fellow in the Institute for Global Health of University College of London, UK, and is also substantial faculty member at the Utkal University, Bhubaneswar, India. He is the director and lead of the Central of the Excellence in the Environment, Climate Change, and the Public Health Policy, a joint initiative of the Government of India and Odisha since 2023. He has a humble H index of 81 and the cumulative citation over 1,66,000. He has published extensively around 284, more than 285 peer-reviewed scientific articles and book chapters in journals of global and the reputable journals. He is a leading social thinker and the global health leader in the global south. Over to you, Professor.
Myself. Okay, thank you. So thank you so much, everyone. Thank you for the generous introduction. So I hope you're able to see me and hear me all right. Please, could you give a thumbs up? Okay, great. Thank you. So the topic of today's presentation is agency and dialogue as tools of attitudinal change towards mental illnesses and mental health, global health policy implications for LMICs. So this is basically a little bit of critical attitude and perspective on some of the mental health care practices as well as the theorization related to that in our global south. So yeah, okay. So mental health, as you know, has been realized as an important concern in today's world, but with a shifting focus to global burden of diseases, in which actually I have been also an author on many of those papers, and how much means in the sense like we are quantifying the mental health and comorbidities. They contribute also to financially and by adding to the suffering and state of care. So a momentum spearheaded by the global mental health approach does promote acknowledgement of mental health issues as a reality that we grapple with. However, it doesn't tell us how much of that will be achieved, especially in nations which are still struggling, just like in our LMICs. Also, countries which are facing issues related to the geopolitical order, instabilities and political instabilities. In LMICs, where most of the world's poor people and even world's people live, notion of health and well-being and especially the mental illness is still a subject attached with much stigma, right? I know that I'm coming from a pure pharmaceutical talk to a little bit of more global health and social science orientation. So I'm going to adapt a more critical approach to this. Health systems around these countries have historically witnessed an abysmal and unfortunate condition. In this regard, a rigorous analysis of three interrelated issues deem our reflection, and that's something which I'm going to talk about, and I'll wrap up the talk with a case study that we have done in Odisha. Do poor people suffer from depression? This is a debate that began way back a few years ago, where Derek Summerfield, a psychiatrist with National Health Service in UK, who has published papers on violence, mental health, etc., says that the symptoms displayed by the patient, like anxiety and unhappiness, they are basically the result of poverty and cultural differences, not depression. In a debate with Bikram Patel, who is at McGill University, who is right now at Harvard, he said these are people who are struggling to find lunch for their children. But Patel's response is that poor people can also get depression just as the rich people. It's not about the rich versus poor, but mental health is equally and universally applicable to everyone. So the notion of mental health in LMICs, where in LMICs is a bit different from the global north. Healthcare professionals, researchers, as well as people in general are faced with a challenge when dealing with the mental illnesses. For example, internal representation of mental illness in terms of its immutability, and the prevalent assumption has been that these hapless folks are devoid of control over their own desires, feelings, emotions, and hence the contingent action, disposing them to precarious modes of life and susceptibility to exploitation from different parts of the society. This traditional perspective is in line with an attitude which advocates regarding the lack of agency and free will. It means many people having or suffering mental illnesses do not have any agency and free will. This has remained as one of the biggest concerns for the health practitioners, and majority of the health practices have always emphasized on surveillance system and control check on the activities of the mentally ill, both suffering and the recovered ones. Unfortunately, the notion of global mental health doesn't render any meaning in this direction. So health and well-being, common knowledge and practices. What are the common knowledge and practices in Global South? So there is a seamless stigma, outcasting, deep feeling of contempt attached to this issue, and overwhelming abhorrence of to these suffering people. There is presence of fear, anxiety, feelings of guilt among family members of the ill. The massive awareness on the issues is barely scarce and insufficient. Largely, the gap filled with superstitious beliefs and mythic representation. The mass consciousness is filled with prejudicial superstitious beliefs, derogation, and attempts to condemn the insane. Though the mental health movement has taken its momentum, but it has been majorly restricted to the professional's knowledge and professional domain. It has failed to reach the common man's cognitive repertoire. People really don't, engage much with the mental health as much as they engage with physical health issues like cancer or diabetes or heart diseases. Health and well-being, common knowledge and practices, individualistic approach to the healthcare in India. Mental health is purely individualistic, it's not very community-oriented. Is this system of glorified individual care really at all? This is a question that I would like to ask. I would also like to ask, are we able to care for the individuals proficiently at an individual level? And do we have trained specialists and professionals to deal with? This is a concern that has probably been prevalent in the majority of the global health system as well as public health system, and this concept we call care crunch. Severe shortage of resources also greatly limits the amount of care that patients and the caretakers can receive. It's not just patients who need care, caretakers also need care because there is a lot of caretaker burden. The individualistic care, though valorized, some of its aspects has its own loopholes, and first is majorly emphasizes on monopolistic and capitalistic system which inherently advocates providing healthcare facilities to individuals, the garb of individual care and attention majorly to the affluent and those can afford. Okay. Second, the current prevalent system is very much limited by the degree and magnitude of its actual utility value as a byproduct of its lack of mass accessibility, urgent care system, and availability for the poor. So there are some mental health therapeutic needs in LMICs. 70% of the people in this country who need psychiatric services receive nothing. This is what Alan Kasdin said long ago. That number comes from several studies, including 2 published in the Annual Review of Public Health and JAMA Internal Medicine. The truth that we are not treating everyone in need, and we cannot do so if we insist on only one-to-one therapy at a clinic with a mental health professional. So what are the concerns? Recognition of a need, the demand. We need to understand and recognize the need and demand. We need to also work on the causal beliefs, lay health seeking beliefs, professional health seeking beliefs, cultural narratives around mental health therapy, etc. So what are the issues around paradigm of global mental health? Much of the narrative around global mental health focus on epidemiology and classical positivist approaches focusing on numbers as a mere disease cluster. These approaches, they fail to underscore the intersectionalities. I don't have the time, unfortunately, to explain the concept of intersectionality. I'm sure some of you or most of you heard of it. Cross-cultural diversity and complex yet beautiful multimodal interventions geared to deal with the psychosocial issues, which cannot simply be understood using such reductionist approach. This is unfortunately true. Ironically, there are several deeply cultural, professional, profoundly personal issues that surround mental illnesses in narrative, counter-narrative, subjective-based notion and madness, and how they are dealt with all over the world, and especially in the global south. Although it's seductively apparent that global mental health is benevolent, it's only to deceive under its garb of medical imperialism. Therefore, ontological realities of a developing nation and subjective notions around mental health and illness cannot fully fulcrum on a generalist pedantic notion of global mental health, as it almost negates minority perspectives, marginalities, subjectivities, equity, and development, much of which come from global south. Issues around great divide between professional and lay. This is something which has been persisting after several decades, although there is a lot of theorization and writing on this issue itself, but it has actually left the scene. And so what are the issues? This becomes an important issue, especially when we talk about methodological realities as to how do we intend on having mental health for all under the UN's mandate for universalization of healthcare. And often when we talk about universalization of healthcare or universal health coverage, we really don't talk much about mental health. We often talk about other things, including the finance, health financing, and insurance schemes and also how we can make healthcare available to all. But we do not actually talk as much about dental care and mental care. Both are severely ignored. In the recent years, with increased realization of the infrastructural scarcity and care crunch, NGOs have come up with multimodal participatory interventions in the community with the express purpose of spreading awareness regarding mental illness, and some of it has been also successful in eradicating the stigma and creating sustainable systems for community practitioner interaction. These sincere efforts with the use of health literacy efforts have emphasized on increased community participation, the role of a user-driven healthcare planning and delivery reorienting our focus to the agency and participatory dialogic practice. I'll explain what is participatory dialogic practice in the next few slides. This paper with basically aims to address the need of breaking the boundary between the elite professional authority and the lay recipients of care, and the possible potential role of civil society NGOs that can play in bringing the agency in persons with mental illnesses to free-flowing dialogue, its implications for health policy planning and delivery, especially in a country like India. And I'll also treat the case. So what is practice? Practice basically refers to a process of critical intellectualizing and internalizing of cultural attributes while allowing for sufficient reflexivity, whereas dialogue leads to critical reflection, first step of the practice, coming from Paul Frederick, and instrumental in developing one's cultural and situational consciousness, coming from Dorsey. Okay, so critical reflection and reflexivity, which are not the same, one can decide on and conduct themselves of appropriate action, which mostly moderated through a cultural consciousness for determining the appropriateness of the response. Hence, culture and society plays an instrumental role in one's introspective abilities, degree of empathy and self-reflexivity, etc. So here, participatory practice is basically committed to mainstreaming the voices of the poor and marginalized section of the society and everyone who is basically not having any voice in the process. So what is prefigurative practice? Prefigurative practice basically emphasizes the relationship between action, research and practice and the creation of alternative to the existing social order. So I don't have a lot of time, so I'll be very fast. Participatory dialogic practice, it's basically the dialectical relationship between people and systems that Seidman suggests offers a ground for increased dialogue and voicing of true concepts of community members. This kind of relationship emphasizes on a true realization of the needs, concerns, challenges, strengths and opportunities present in a particular community, and we will also take it as an indicator of designing programs in consultation with the community. And so obviously community plays an important role in the decision making and also policy making as far as the healthcare is concerned. So for the optimal realization of such changes with active harbingers from community development agencies, whether the government, non-governmental organization, community-based organization, or other civil society organization have to define or redefine their roles as facilitators of such participatory processes in development. And the same can be also used in mental health care. This is something which has not been very actively used. So engagement with development agencies and organizations is a critical component of participatory development advocacy. However, many times that has been used in development studies, but not in mental health care. So dialogue agency and experiential learning is something which is very much at the heart of community mental health, and that needs to be taken more with more vigor. Action and agency in dialogue. Obviously, action agency plays an important critical role. So what happens when people communicate or dialogue with each other? This is the daunting question that this book proposes to ask in this particular book. We have paraphrased here Austin very long back actually, because most of what we are talking about is coming from community development and international development perspective, but not much has been used in the mental health care. And we have used that model here, and we have tried to, I'll skip a few slides so that I'll just skip a few slides so that all of you can go ahead. You can see this. So Francois Coherent helps to explore the unexamined assumptions about our extraordinary relationship with non-humanities. In a detailed study, he talks about who holds the agency, and he also talks about what can we do about it. So I'll not go in detail related to this because this is not actually essential here. But I will definitely like to focus on collectivism versus individualism versus mixed isms. Why? Because many times the global south and north are opposed as if they are basically different models of each other. So contribution of lay knowledge to the understanding and promotion of mental health is something that has not been talked much. There is a huge amount of trust in the biomedical model and authority. Authority, that means surrender. Does this negate and corrode one's agency? Maybe, and still maybe not. And we also need to talk about indigenous knowledge co-production, which is very much ignored. Then there is agency in engagement. What are the factors, shapes and outcomes? We need to talk about that. There's a lay professional alliance, dialogue and engagement as routes to agency. That is something that we also need to focus on, and that is something which we have tried to use it in our scheme. So are the lay partners ready? This is also a question that that begs attention. Why? Because many times we assume that the lay partners, many times, first of all, they are not even given the due acknowledgement that they can act as a partner, because professional dominance is too high and heavy in the mental health as well as in healthcare setup in particular. And when we are talking about capacity building on depression, which includes familiar nomenclature, biopsychosocial elucidation of the illness, lifespan approach, life course approach, understanding of its impact on various domains of functioning and the treatments, I think we need to go beyond our traditional models of treatment. We also need to form a therapeutic alliance and assemblages, and we also need to understand the tensions and contestations which occur as a result of that. The therapeutic alliance is a critical determinant of individuals' persistence and outcomes in mental health treatment. Simultaneously, individuals' community networks have decisions about whether and when and what kind of treatment are used. Despite the similar focus on social relations influence for individuals with serious mental illnesses, this line of research has maintained an almost exclusive focus on either inside treatment or networks or outside networks, respectively. So why alliances don't foster? Because deep-seated insecurity of the professional, challenge to hegemonic power structure, agency opposed to authority, voices opposed to silence and domination, culture shift causes tension and conflict. For example, Patel's suspicion is that the professional community was threatened by the use of paraprofessionals with comparatively light training, which some of his studies in India with Sangat and other organizations did. And that is something which I would also concur based on my work. So collaborative engagement, the tridents, there are 3 tridents here: survivors, professionals and consumer. They can all come together and they can do a lot. So there is a synergy. We need to stop being obsessed with the artifice of psychiatry to post-psychiatry mix now. Okay, this is the model that we developed in 2010 and finally got published in 2 different papers, 2010 and 15. This is the model that we have used to bring multi-stakeholders to come together, the community being at the heart of it, the family and relatives and individuals with mental illnesses, and those who are survivors or those who are basically being recovered from the mental illness. So what are the aims and rationale of this approach? To instill values of competence, emotional and psychological, and empowering the community gradually by reassuring of their strengths, heighten the degree of resilience among the adversaries of the social situation or in any trauma undergoing the psychosocial crisis, enabling them with the positive armor to protect them from the pessimistic forces and to create forces within the community, which will be basically encouraging them to become radiating energy, etc. It means basically support. Sharing personal experience and concerns, seeking solutions to the community can be helpful. I have borrowed a few anecdotes from some of our work. So now let me take you to the field study which we have done. This is a very longitudinal study. This is not a recent study. Okay. There is a few questions, comments coming. I really don't know. Okay. Your slides are not changing. Why are they not changing? Okay. I have shared my screen. Maybe I can do one thing. I will stop share and I'll share again. Yeah, that's all I can do. Because they are changing at my end.
Now they are changing. We
again.
are stuck with the slide number 13. Now it changed to 31 suddenly. So now you can proceed.
Okay. I'll just show the model that, can you see the model right now? No, because I have stopped sharing.
Yeah, you have to share it.
Yeah. Okay, sorry. Okay, I don't know how that happened, but I hope you can see the slides now. Yes.
Yeah. Now the model is visible.
So let me. Yes. So the model that we got published in 2010 and 15 twice, and this is a model at the heart of which basically there's a lot of integration of communities, people surviving from mental illnesses, and people who are actively also going through some form of mild illnesses at the moment. So this is the map of Odisha, my state, at least urbanized state of India. However, it is also growing very fast nowadays, which is probably giving us mixed feelings all at the same time. So I would just go ahead in this form. Maybe it will show properly. I really don't know why the slides have come. Please let me know if the slides are moving now. Can you see this new slide? Hello? Can you please confirm if you can see the new slides? Yes? Okay. to the new slide where I'm showing the putting indigenous mental health into perspective, because Odisha, the state that I belong to, has more than 62% of the original 60 types of tribes, and few of the most tribal people, means indigenous people, live in our state itself. So I'm going to present you a case study in one of the tribal places. It is a case study on a particular residential care home called Janani, a home for survivor women. From Chaudhar, Cuttack, Odisha, is a home for mentally challenged women, all from socio-economically whose backgrounds they stay there. Most don't have a family anymore and were left abandoned. So obviously, most were rescued from different parts of railway stations, trains, and other parts while getting trafficked, and is built on a 15-acre land surrounded by mountains and villages with farmland and offers natural and sustainable ecosystem. Suitable ashrama engages the residents of life, building on productivity, the work and help in the culture, and many green vegetables, and also create place with nature's best support. So here I'm trying to talk about one concept called communities of care, because here this is particularly applied in this particular community-led effort. So we are now also talking about, can we build communities of care for them? Communities they themselves will be operating as safe and enforcing, will also encourage each other with on their positive strengths and help achieve the ultimate resilience. That is a question that we have been asking, and we tried to do this. And I think over the past more than 10 years, 12 years, I think we have been able to get some sense out of that, because most of the residents who are living in this community-led home, they are
Hello. Thank you, Professor Maheshwari, for the powerful. Hello. Is Professor Maheshwari is there?
Dr. Maheshwar is there online. Professor Maheshwar Satapathy is there online.
okay. Yeah, apologies, I was cut off for a minute. I am going to screen share again. So I'm also going to turn up my camera in case the internet might improve. Okay, so here I'm going to show some of the pictures from our Janan Ashram in Chaudhar, Odisha. The producers, entrepreneurs, co-creators, co-system, where women who have been suffering from several mental illnesses are now recovering, are on a path of self-discovery and growth. And they are also co-producing in these farmlands. I hope you are able to see my slides. Can you please give a confirmation?
Yes, sir. You can. We can see.
Okay. Okay, thank you. So the next slide, which I'm showing, proud producers of vegetable, because we regularly visit them. Previously, we used to visit them twice a week. Nowadays, we are visiting maximum once in fortnight, because there are some other members who are also taking care of the thing. So in this particular ashram, there is around 10 acres of land is purely used for agriculture, and they are producing vegetables which are consumed and is also sold out at villages who are living nearby, and that is being produced by all the community. And let me tell you, this particular residential home has more than 200 women who are living there, and they are very, very active in terms of their day-to-day activities, and they're also extremely jolly nature. They interact very, very. We get the affection and love on us, and as you can see clearly, they are very actively engaged in the harvest. Harvest of hard labor, and they are very proud entrepreneurs also, because some of it is also getting sold and money is getting generated for their care. Then there is also joy of cooking, because when we visit, we always cook, and there is a meal, collective community meal together. We have meals. The houses have been recently built. Some more houses have come up. This is a little older picture. So they cook, they serve the food, and we eat together, we interact among each other. As you can clearly see, this was from one of our visits, and we have cooked and we also feed, and I think there is a sense of community that we try to foster here. And we also take some of our students from time to time just so that they can observe and engage with them and they will learn. And many students from psychology department and other medical sciences, public health department, they also visit us, and they experience firsthand as to how to deal with people with mental illness and mental health issues. And that's something sorry, very essential for all of us to understand. This is just one of our core team members, Dr. Anna, and one of the persons who is very happy that such kind of activities are happening here, and so many young people are coming to visit them on a regular basis. These are the residents of the community, and true engagement builds on equality. So without having a true equality at the heart of it, I think we will not be able to make any progress. And this community, this experience of over past more than one decade, which I have had with this residential care village community, I think it has paved the way. It has also helped me to evolve as a professional, also as a person, in a great deal. And I have learned so many important values and principles. And we try to encourage voice and agency of all the residents in this place. And as you can clearly see, they are always available with us, and many of them actively interact with us, very actively. And they crack jokes, they tell so many important stories about their lives and many things. As you can see, there is a mic, a person is holding the mic, the girl is holding the mic, and she is talking something about some of the things, and she also sang a song during this particular meeting. So basically, our model focuses on 4 things: a continuum, our journey towards building agency. So we start with engagement, we go to dialogue, and then partnership. We build partnership, and then we try to foster agency among people who have somehow lost it due to the pressures of the society and also the debilitating effects of mental illnesses. What are the unique strengths of Global South? So we need to talk about it because our effort lies in Global South. Collectivism. We have a huge amount of collectivism in the Global South. I think that is our core strength. The stronger family system ties, they are extremely useful. Community orientation as a default is our core forte, and I think we need to build on that. Mental health as a part of well-being agenda can be included, and community participation and support is higher. Cheaper and cost-effective means of care are possible in our context, and we need to build on that, and we need to foster that. Cultural innovations into therapeutic needs to be integrated, well integrated. I think psychologists, psychiatrists, and all other mental health professionals, everyone who is dealing with neurological and mental disorder, they need to work together so that they can work on it. So how do we grow? We need to grow on complementarities, not contestations. So we need to focus on pluralities, subjectivities, multiplicities of voice and identities. We need to build on engagement, dialogue, and partnership between different stakeholders. We need to listen, and lots of active listening. So global partnership focusing on a combination of global and local model, which we call local models, converging to produce a local conglomerations, and assemblages entangled around intersectionalities need to be built into our systems of care, as well as everything that we do into therapeutics. We need to focus on articulation and not silences. We need to focus on building a team, not building onto the power structures that we have that have been deeply embedded into the system. We need to learn from each other with a paradigm shift. Rather than building on like we are experts and they are lay, we need to come together and need to work together to make a change in the collective attitude change. So we need to move from individual to community focus on orientation. We need to be serious learner observers to experience knowledge, and we need to also move beyond the global north led dominance to global south examples and create exemplars in mental health care. And we need to move beyond best practices to integral reflexive practices. I think that with that, I would like to sum up my talk. Thank you so much for the opportunity. It was wonderful to come here. And thanks, Reynard. Thanks, Dr. Sujit, for this brilliant opportunity. I think all of you are doing brilliant work. Thank you so much for the opportunity. It was lovely talking to you.
Thank you, Professor Maheshwar, for powerful reimagining of global mental health. Your call for decolonization and the locally rooted approaches resonate deeply with the realities of LMIC. We are reminded that the health and the well-being cannot be imported. They must be co-created with the community. The shift from the professional hierarchies to the dialogic participatory praxis is not just desirable, it is urgent. As we move to the system strengthening, your insight set the perfect stage for rethinking human capital in the global south. So I just want to put to the all the audience for the any of the questions they want to put on. Thank you so much.
Thank you. If anyone wants to ask any question, you may please kindly ask me. I will be very happy to respond.
So how do you think? Sorry, thanks for this very exciting talk. Thanks for this very exciting talk. It's Rainer here. Hi. And I would like to say, how do you think you can spread this? I think it's a very welcome, but I think we had something similar from a talk about Kenya, where they're very much focusing on the community. But how would you strengthen that, and how do you move forward in this approach?
I think one of the ways it is possible is if we try to scale it up across the breadth and length of the country. Let's say India is with 1.5 billion people. If this is an exemplar in mental health practice, community-led mental health practice, I think we scaled up, it can be widely taken onto larger scale by taking more out. Possible if we work with the civil society and individual survivors of mental illnesses and their caretakers. That is only possible if we harbor on the strengths of communities. So unless we take the communities on board and their shared decision making, and their power of collective, will not be in a position to do it all on our own. Even a state or government cannot actually implement it. Like if, let's say tomorrow, government of India or government of Odisha decides that we'll create 200 Janani homes over Odisha, but still it will not be sufficient. Why? Because there is not much of integration of the community and community voice, community-led decision making, and community being at the heart of it. So community needs to be at the heart of it, and that will be the only way all these kind of ways or systems can be more integrated. It depends.
I think if there's no other questions, and I think you're very busy, and you're going to another meeting, Professor Maheshwar, and thanks a lot, and yeah, thanks for your contribution.